And the question is, which of these 5 things is it not likely to be? And if we look at these possible things, hemangiomas in the nasopharynx, I could imagine that. Some sort of infection that results in bleeding, that might be possible. Trauma is always conceivable. But what would appear to be unlikely is an adverse reaction to systemic antibiotics, even if it's something like Stevens-Johnson syndrome, which is characterized by bully and these kinds of awful things. I would think that that would be the least likely to be responsible for this condition. And that's the correct answer. And next week we'll find out details on why this person is crying blood. In the Middle Ages, if he would have done that during the daytime, he would have been eligible for sainthood. But if he did it at night, he'd get burned at the stake for being a witch. And we'll go into that later. Here's another example. This young lady has been crying blood for 2 years. And she has hyperemia and increased vascularity of the tissues here in the nasopharynx that somehow was responsible for this condition. So there are a number of case reports in the literature crying blood, but I could find none that were related to antibiotics. The big theme in this week's New England Journal is cystic fibrosis, which used to be called mucoviscidosis in English-speaking realm, which is probably a better term, and in German it's called mucoviscidose, because this involves mutations in a chloride channel in all exocrine glands throughout the body. And that's important to keep in mind because this is not strictly just a lung disease. Cystic fibrosis is the most common autosomal recessive disease on the planet, and there are about 100,000 people that suffer from this disease. And the treatment is miserable. These people used to die in childhood. With conservative management, which has certainly improved, and the development of antibiotics, their survival rate has increased to adulthood. But the challenge is how to get this chloride channel working. And this is termed the, I'm going to have to block you out, young lady. This is termed the cystic fibrosis transmembrane conductance regulator protein, and that complicated term is abbreviated as CFTR. And CFTR is actually conducts chloride outside of the cell. And the bad news is that there are probably 10,000 mutations in CFTR that can cause this syndrome. But the most common that are responsible for 70% of cases are listed here, and the most common is the delta, that's a small deletion of phenylalanine, the 508 mutation, but there are others that result in stop codons, amino acid substitutions, splice mutations that result in a truncated protein, etc. So the molecular genetics of this is complicated, and the delta F508 is the most common mutation, and is probably responsible for about 70% of patients who have this problem. Now, clinically, it can present at birth with meconium ileus, and that's a medical emergency. But if the infants survive, then probably lung disease is the most prominent manifestations. And the cilia coatings of the small airways are destroyed, as shown here in this electron photomicrograph. The patients get clubbed fingers. They obviously produce tons of mucus and cough a lot, and that's responsible for these rib fractures that are shown in this reconstructed CT. And so the problem is CFTR doesn't work properly, can't conduct chloride outside of the cell. Now, some of the mutations result in a channel that is defective. Other mutations result in folding problems so that the protein is not stored in the Golgi apparatus, but instead is ubiquitinated and digested in the proteasome. and other mutations result in a translational defect where because of the 508 deletion, for instance, additional material isn't produced. And the challenge is how to develop pharmacological interventions that can deal with all three of these possible problems in the framework of all of these various mutations that can happen. Now, for years, grandmothers have noticed that children with this syndrome taste salty, which seems kind of counterintuitive if chloride can't be pumped outside of the cell. And the reason for this collection of high concentrations of sodium chloride within this very viscous mucus is still not perfectly explained. There are several hypotheses, the high salt hypothesis and another hypothesis that involves the epithelial sodium channel. That's still not entirely clear, but that's an important clinical finding because we measure sweat chloride in order to establish a diagnosis in these patients. Now, the medications that have been developed to deal with this problem directly include so-called correctors that deal with the faulty folding of the protein. Another possibility is to get channels that are actually implanted to function more effectively. That's also a possibility. And a third possibility would be to get around the translational defect where a protein is produced that perhaps has a deletion, but that's nonetheless better than not having a protein at all. The papers that we're going to discuss involve second-generation correctors that attach to the CFTR protein at different places to try to deal with this faulty folding so that the protein is then moved to Golgi and then implanted in the membrane. And what was done in these studies, this is a triple therapy directed at CFTR. Ivacaftor is a drug that increases the efficiency, the functional capability of the channel, and then VX659 plus tezacaftor are two drugs that deal with the folding problem. That is, they're correctors. And the way these studies are constructed is that the patients were recruited, and basically there are two studies in each of these papers. The first study has to do with showing that this strategy, this triple therapy strategy, results in the more increased placement of these proteins in the membrane, and that chloride transport is enhanced. That means to say that sweat chloride decreases in concentration with the therapy. So if we look at the patients that were recruited in these various arms, the multi-dose studies, these are cystic fibrosis patients. They're in their 20s or very early 30s. They have already a reduction in forced expiratory capacity of almost 40% across the board. The sweat chlorides are all elevated to the same degree, and this is a score on their respiratory abilities and qualities of life, and that's obviously here diminished. So the patients across the board look similar, and you probably will not be able to appreciate exactly how this is done, but here's phase 1, different doses of this material, and then the randomized trial at these different doses, and also patients that received only two of the drugs plus placebo, and the follow-up that was done. And what we can see here in the phase 1 study, there's increased expression of CFTR in these immunoblots where it's supposed to be, and densitometry of these immunoblots also looks like there's a favorable response, and chloride transport across these channels is also increased in a dose-dependent fashion. And if we look at this, serious events in this first part are practically zero, which is extremely encouraging for this kind of study, obviously. And if we look at these sweat chloride values, this is percentage decrease. And so with the active compounds here, all three of them, we have over a 40% decrease in sweat chloride compared to placebo, where there's hardly a discernible decrease. So it looks like this strategy might function. And if we look at these graphs here, looking at absolute change in FEV1 increases substantially with the treatment compared to placebo. The graphs here on the right have an additional adjustment compared to those here on the left, where the different doses of compounds are also shown. But it looks like that there's a favorable influence on FEV1, which would be very important. Sweat chloride drops over 40%, and this respiratory domain score is also substantially increased. So that it looks like this triple therapy of this new experimental compound, plus the two older treatments of the channel enhancer and the older corrector of malfolding, add a substantial advantage to help these patients. And the second study is exactly the same as the first study, except it deals with a different corrector drug compared to the first study. But otherwise, the study is built up in the same way. The sweat chloride values of these separate patients that were recruited for this study are also substantially increased. Their age range and their FEV1 scores are also similar to the first study. And the results look very, very similar to the first study. There's increased expression of the protein. The densitometry findings support that view. Sweat chloride transport is substantially increased in a dose-dependent fashion. Serious events, hardly any. And sweat chloride values plummeted to a similar degree as in the first study. The respiratory domain score improved substantially, as did the FEV1 in a fashion that was similar to the first study. So these are two almost identical studies designed in the same way, looking at different correctors, second generation correctors of the malfolding of CFTR. And it certainly looks like this approach is going to have something important to offer these patients. And if we look at this editorial, the editorialist says that these reports represent a major breakthrough in cystic fibrosis treatment. And what's also important is these compounds deal particularly with this most common mutation, the deletion that deletes this phenylalanine at position 508. So this is going to be a substantial advance in cystic fibrosis treatment. Next topic is tuberculosis, which is far more common than cystic fibrosis. And this is still a major health problem, particularly since advances have been made in treating malaria and treating AIDS, etc. Tuberculosis is the most important cause of infectious disease death that there is on the planet. And these bacteria have an outer coating of a lipid and carbohydrate material, which makes the development of antibodies against these things a difficult proposition. But indeed, the study has to do with a new vaccine that's been developed for tuberculosis. And this vaccine was tested in African countries where tuberculosis amongst young people, whether or not they have AIDS, is a major health problem. And these youngsters most of them were already vaccinated with Bacille calmette-guerin, and this is an attenuated TB bacteria, which is believed to offer vaccinated persons a protection of about 50%. So a lot of these kids were already vaccinated with this material that subsequently got the vaccine that I'm going to show you in a minute, or a placebo injection. Now, what is this vaccine? I don't really know. And the company that makes it is not too interested in letting me find out, but this seems to be a recombinant fusion protein of two proteins that are expressed on the surface of MTB. And this looks fairly promising. So it's one of these vaccine studies. They're pretty difficult to follow, and I don't understand them personally either. But we can look at the 3,500 young people underwent randomization, and 1,788 received placebo injections, and 1,787 received the vaccine. And the endpoint here is who gets TB and who doesn't. And all of these people already had latent TB. That means that they had this interferon release assay that's done now instead of doing a skin test was positive in all these individuals, but their sputum was negative for MTB. And what we see here is that the vaccinated people have a better outcome than the placebo individuals. So at the end of 3 years, the difference in the vaccinated people and the placebo people is 50%. That would imply that this vaccine, above and beyond whatever BCG might do, offers another protection of 50%, which would be a substantial advance. And serious events, well, getting open TB would be a serious event. So the vaccinated group, the vaccine was tolerated pretty well, and open TB was reduced in half. So this is also important because 1.7 million TB deaths annually, if that could be reduced by a substantial amount, that should certainly be done so. And the groups that need to be vaccinated are in those parts of the world where open TB is a common problem. So that looks pretty good. The review in the New England Journal is diverticulitis. Over half the people above the age of 60 in Western societies have colonic diverticuli. And if these diverticuli become infected, rupture, cause abscesses, peritonitis, etc., we call that diverticulitis, and this is a common problem. In Caucasians, the pain is usually left lower quadrant. In Asiatics, it's mostly right lower quadrant. This has something to do with colonic construction that I don't understand. But we're given here a patient, he's 57 years old, 48 hours of pain. He's had previous episodes already. He has a temperature of 38.8 degrees Celsius. Heart rate's 110, so he's got a tachycardia, he's got leukocytosis. Could be moving in the direction of sepsis syndrome. We are given his blood pressure, but perhaps we don't need to know that. And so we need to know something about diverticulitis. It's getting to be more common. It's associated with obesity. It's associated with a diet that's low in vegetables, or what we call in German Ballaststoffe. Forgotten what that's called in English at the moment. You'll have to forgive me. A high fiber diet, yes, exactly. We were taught that eating seeds, nuts, and popcorn were contraindicated, but that's all nonsense. You can eat all the seeds and nuts that you want. The patients are usually first given antibiotics, although it's not known with 100% certainty that helps them, because condition might get better on its own. Surgery is reserved for individuals that develop complications such as perforation, abscess formation, or open peritonitis. And that is fairly common. So what we see here in this colonoscopy is this is basically normal mucosa, and here are these outpouchings that form where vessels perforate to feed the colonic mucosa, and these are diverticuli. And the idea is here that they're filled with incretions that become obstructive, and then lots of bacteria, and then infection and inflammation, etc. Now, CT has made substantial inroads in making the diagnosis of this problem, and the sensitivity and specificity of CT under these circumstances is over 90% for both variables. And I think this is rather difficult. I can't read these things, but an expert can. Here's free air, and here are abscesses that are formed in these patients with diverticulitis. Smoking, anti-inflammatory non-steroidal drugs, physical inactivity, obesity, all of these things that most people exhibit are associated with the development of diverticulitis, and perhaps that's why it's so common. Diets low in fiber, I have to remember that, seem to play a role. So all that. So, but there are still areas of uncertainty. When should a surgical intervention ensue? What kind of surgical intervention should be performed? What sort of antibiotics should be given? And ciprofloxacin, metronidazole to cover anaerobes are commonly given, although ampicillin and clavulanic acid, amoxicillin and clavulanic acid also are commonly employed. So there's a lot to learn about that. The second review in the New England Journal has to do with aplastic anemia. And I didn't know this. The first case description of aplastic anemia was published by Paul Ehrlich in 1888. But Louis Vasquez introduced the term aplastic anemia. And there are various genetic causes that germline mutations, telomeric mutations, the Fanconi's anemia, GATA2 deficiency, CTLA4 deficiency, and this sort of thing are known to cause this problem. But there are also acquired forms of aplastic anemia. When I was in training, chloramphenicol was a cause. That's not even mentioned in this review. Exposure to benzene and similar toxins can also destroy the bone marrow. But almost all sporadic cases of aplastic anemia, that means the ones that aren't from one of these genetic causes that I mentioned to you, are autoimmune problems. And they're best initially treated with cyclosporin, and then there are also other options. So that's what this review is about. So here are the mutations that I mentioned, aplastic anemia, the myelodysplastic syndromes that we've talked about recently can result in something similar, and then finally result in acute myeloid leukemia. What also has to be kept in mind is that paroxysmal nocturnal hemoglobinuria, which is a somatic mutation in the PIG-A gene that codes for this GPI anchoring protein, is also associated with aplastic anemia, and there are specific treatments for that, and that condition has to be kept in mind. So stem cell number, stem cell clonality, telomere length, and PIG-A mutations, PNH, which is not that common, but we saw that in the clinic periodically, can also result in aplastic anemia. The treatment has been revolutionized by immunosuppression and bone marrow transplantation, which is now much more successful than it was in the past. And then here are the results of treatment, and it looks fairly favorable, and that's what this review is about. Androgens have been used for years for marrow failure syndromes, although cyclosporin seems to be a better idea, and bone marrow transplantation for patients that need it. Then there's this patient shown in the New England Journal. It's a 62-year-old person with back pain, and he gets this MRI, and he's got these two white vertebrae here. And whenever I would see that, I would think of, if it's sort of a chronic problem, this has to be tuberculosis, and if it's an acute problem, it has to be Staphylococcus aureus. But this was a chronic form, but it wasn't tuberculosis, it was Brucella melitensis, which can also cause this kind of osteomyelitis. The case in the New England Journal involves a pneumonia, which caused me to bring up this anatomical diagram. You'll remember that the right lung has 3 lobes, including a right middle lobe, and the left lung has an upper lobe and a lower lobe, but it also has a lingular segment. And when I was in medical school, we were always taught that a pneumonia in the right middle lobe or a pneumonia in the lingula need particularly careful attention because they might have a specific cause and require a different diagnostic approach. So our patient is a 57-year-old man who is admitted to the second hospital with this problem because of confusion, fever, malaise, and weight loss. And here's his chest x-ray. And here's this area of consolidation, which removes from view this left heart border. That implies that the pneumonia is in the left lower lobe, but in the lingular segment. Then he has this electrocardiogram with ST segment elevation in 2-3 and AVF. And that's really why he was admitted. And he's pretty darn sick. The story goes as follows. Several weeks earlier, he developed symptoms of pneumonia and presented to a hospital and was had a temperature of 38.3 degrees and had a tachycardia and was breathing 24 breaths per minute. Sounds severe enough to put him in the hospital. They put him in the hospital. They did a chest x-ray. It showed this lingular pneumonia. He was treated with piperacillin, with tazobactam, ciprofloxacin, lorazepam, propofol. Good God, I don't know. It's sort of a Wilhelm Busch syndrome. Onkel Fritz in großer Not haut und trampelt alles tot. So they did this for a couple of days, and he got some better. They sent him home. Then the same thing develops again, and then he's admitted to the second hospital with the same problem, lingular pneumonia. Past history, 1 pack cigarettes for 41 years, not bad. He drinks 8 to 10 beers per evening, also not bad. Tops that off with 2 to 3 glasses of wine for starters. He's a farmer, restores farmhouses, cleans stables, and smokes marijuana daily, in addition to all of this stuff. So he's exposed, he owned sheep and goats and previously had owned exotic birds. All these obscure questions that we asked the patients were apparently all positive. Here's a bunch of laboratory values. He's got a leukocytosis, and otherwise they don't help us much further. Here's his chest x-ray, still has that lingular pneumonia. And he gets a CT done, and what we see here is he's got this left-sided pleural effusion, and on the right side he has also now has consolidation, and this lesion here is consistent with a pulmonary infarction. Then we look at this CT here, and he's got multiple renal infarcts, and his head in this MRI also suggests multiple infarcts. So it obviously has generalized embolic phenomena involving emboli throughout the entire body. So he gets echocardiography done. He gets a transthoracic echo, and his mitral valve leaflets are thickened, and he has a little bit of regurgitation. And finally, they do bronchoscopy on him, which I think they should have done in the first hospital for a lingular pneumonia, particularly if it doesn't go away immediately. And various tests are done for bacteria and all sorts of things, and these are largely negative. Then he gets transesophageal x-ray, which shows vegetations on the mitral valve leaflets on the lines of closure. And that's shown in these reconstructions here. So basically, he has a form of endocarditis with thrombus formation on his valves. So he gets a ton of studies done, cultures for everything, antibodies for everything you can imagine. But the bronchoscopy shows the root of the problem because he has a non-small cell lung cancer, which explains these thromboembolic events. And lastly, we learn that he has pulmonary adenocarcinoma complicated by a hypercoagulable state. And this is a non-bacterial thrombotic endocarditis. The diagnosis is generally made at autopsy by a pathologist. And when I was a medical student, the pathologists had a specific name for this. They called this morantic endocarditis. This is a non-bacterial thrombotic endocarditis, which can be seen under a variety of Moranti conditions, but certainly is consistent with cancer. Then we learn in the New England Journal that being a cosmonaut has its risks because your brain shrinks, but it looks like it recovers to a degree, but not entirely, as shown in these images that I fished out of the New England Journal here. Then there's a question on epicondylitis. This is known as tennis elbow, and the question is, how do you treat tennis elbow? So I had to look that up, and actually the treatment of choice is this contraption here, an orthodesis. I'm not quite sure exactly how this one works, but the question is this: which one of the initial management approaches is best for a patient who has lateral epicondylitis, otherwise known as tennis elbow? And he gets ibuprofen, got to have a pain pill. And the question is, should we inject this area with a glucocorticoid? Should we inject it with lidocaine? Should we inject it with platelet-rich plasma? Are you kidding? Administer glucocorticoid with iontophoresis, or recommend a wrist brace and rest? Well, I had to look this up because there's actually a randomized trial of steroid injections versus wrist braces for tennis elbow, and the wrist braces won. I imagine that this wrist brace keeps you from supinating your arm and puts this at rest, and that beat the steroids, as opposed to what we had last week where, what was it again? It was, doesn't matter, we'll go on. In the Lancet, the first topic involves glucagon-like peptide 1, and this is a peptide hormone produced in the gastrointestinal tract that's been appreciated now for about 30 years, and this stuff is wonderful. It stimulates insulin release, it inhibits glucagon, it lowers blood sugar, it lowers body weight, it's degraded by DPP4 that can also be inhibited. And what's been discovered is that the saliva of this Gila monster here contains GLP-1. And because of this finding, synthetic GLP-1 agonists have been developed, and they do all this wonderful things that makes type 2 diabetes better. And in this particular study, albiglutid was compared to placebo, and the idea here was that albiglutid could possibly reduce cardiovascular events. You'll recall that we've looked at studies involving liraglutid in the New England Journal, where this GLP-1 agonist indeed decreased cardiovascular events, and this is albiglutid. So if we look at the individuals that were recruited here, these are males with high risk for cardiovascular endpoints, also some women in this study, 70% women, men, 30% women, various ethnic groups, and if we look at their characteristics were similar in both groups, but what we see here is in the group getting albiglutid, there's a significant reduction in the primary endpoint, cardiovascular events, and that's also shown here. There was D is stroke. There was no different in stroke. It's about myocardial infarction or requiring an intervention or developing. B is cardiovascular death. So there's no improvement in survival, but there is a decrease in cardiovascular events. The primary endpoint was death from cardiovascular causes, myocardial infarction or stroke. It was a collection of stuff. B was cardiovascular death, and C was myocardial infarction. That was the driver, and that was reduced in the people getting the GLP-1 inhibitor. And if we look at various subgroups, they're all about the same, but it shows an advantage for the GLP-1 agonist, albiglutid, shown here, across the board in looking at a whole bunch of different variables of these subjects. Hemoglobin A1C was reduced by over 1%. The effect on body weight's not too impressive, and the effect on blood pressure isn't terribly impressive. But the effect on A1C was statistically significant. And so the primary composite endpoint was better in the albiglutid group compared to placebo. I suppose that doesn't matter because GlaxoSmithKline has announced that they're going to withdraw this glucagon-like peptide receptor agonist for commercial reasons. I don't know exactly what commercial reasons that they imply here, perhaps because they feel that they can't compete adequately with liraglutid, which showed a similar result. I think what's important about these studies is because our treatment modalities for type 2 diabetes are almost zero, and all the other approaches make the problem worse. But here's an intervention that actually reduces cardiovascular events, which is what everyone wants. Now we have 2 stent studies to look at. The first stent study involves coronary artery stents, a bioresorbable vascular scaffold, abbreviated BVS, compared to metallic drug-eluting stents. And in this study, the drug-eluting stent is a cobalt chromium everolimus eluting stent. Sounds great. So they recruited a large number of patients here that got stent A or compared to stent B, and the primary endpoint was target lesion failure, revascularization, and the idea was non-inferiority. I think what's remarkable is how good these things are nowadays. And so we're probably not going to see a big difference between stent A and stent B because they're already so good. And if I look at the structures of these 2 different stents, I can't keep them apart. But this one is bioresorbable, which may have some advantages. This one is not, but it's made out of cobalt and chromium, and that sounds pretty good also. So if we look at the patients and how they were treated with what anticoagulants and whether or not there are other drugs that they received, this was distributed equally in the 2 groups, and no difference. So they both look great. And target lesion failure hardly happens. There is a very slight difference here, but it amounts to about 1% as far as the authors say 2%, but I can only see 1, but you may draw your own conclusion. But the difference between these 2 stents is trivial. And whether or not they have angina pectoris, that does recur in a minority of patients, but there's no difference in the stents here. And so the 30-day clinical outcomes were no different either. So stent B is as good as stent A. This next stent study I think is more important because it involves stents in larger arteries. And what we're dealing here is peripheral artery disease that we can stage in terms of severity by the Fontaine classification. A little better classification might be that presented by Rutherford, which involves chronic limb ischemia, as shown here. It's a little more elaborate than the Fontaine classification, and can also be applied to acute limb ischemia. That's for background. And then we look at these wonderful stents. And as I recall, during my training, the operations that we did on these patients were terrible. So I think these stents are an excellent idea. And the patients these are stent patients, and so the peripheral vascular disease, and did a lot of smoking, and more commonly in men than in women, and these kinds of things that we had. But this distribution was no different amongst the groups. But what we see here is how much better the patient got. This is baseline for this stent versus that stent, and when they're treated, it's like they're getting a green light, and the number of people that aren't improved or are only minimally improved or actually get worse is very small. and the patients that get better, about 90% of the patients with this stent treatment get better, which was better than we did with our operations. So it looks like there might be a slight difference here, 88% in terms of primary patency compared to 79%. That would be a 10% difference. That might make us more inclined to the blue stent instead of the red stent, but the portion of patients with the target lesion revascularization by some other means, that looks like it's no different between the two groups. Now, the review in Lancet reminded me of this assignment that I had before I started medical school. Our Department of Psychiatry sent us this book from the Middle Ages, translated into English, called The Witch's Hammer. And this was actually a treatise published by a Dominican priest, Heinrich Kramer, and it was published in 1486. And he conducted the Inquisition in Innsbruck, and their job was to burn witches at the stake. That's why this is called The Witch's Hammer. And their subjects weren't doing witchcraft. Most of them were mentally ill. And it draws attention to how patients with mental illness were treated in the Middle Ages. And in this review in the Lancet is, how are we doing with treating our mentally ill? And we look at the problems that are across the ages, and I guess Alzheimer's disease is a medical cause of mental illness, and it increases with increasing age, and drug abuse and other disturbances are more in younger patients, and so we can look at that. But the way that we treat these people worldwide, at least in many countries, is not much better than during the witch's hammer. We can see them chained to a post, or stuck in cages, or being maltreated in many different ways. And that's the topic of this review. We've made pretty good progress on infectious disease worldwide. Even on non-communicable illnesses, we've made substantial progress, but on the treatment of mental illness, we've done rather poorly, and that's what this review is all about. It includes problems such as the opioid crisis, which has increased in the last 3 years 540%. I can't even imagine it. What are those people doing? And that's what this review covers. And so if you're interested in these kinds of problems, it'd be worthwhile to look at this review. I have another topic because I ran across this paper by Christoph Lippert, who's at the MDC. This paper was actually published a year ago in PNAS. J. Craig Venter, whom you may have heard of, is the senior author. And what they did is they recruited Americans in a shopping mall in San Diego, recruited 1,000 of them, took their pictures, then sequenced their entire genomes, and then they tried to recreate what these people could look like on the basis of bioinformatics based on their genome. And this is astounding. So they're African Americans and Asian Americans and Caucasians and Latinos and whatever have you. And so there are 1,000 people, and I think that this is frightening what they could do. The bioinformatics, how it works, I have no idea, but Christoph Lippert can tell you. The faces on the right are made by a computer, and the faces on the left are the photographs. And I think what can be done with this technology is frightening. It's wonderful, but nonetheless still frightening, because it implies that all the data protection laws and whatever have you, people put their faces into Facebook and these sorts of things. I can capture the person's genome from a one-cell nucleus and then construct what they must look like and find them probably in the internet. There are 2 billion faces on Facebook. So I think that's important for the discussion of privacy laws, which I think are back in the Middle Ages along with the witch's hammer. So we'll close with this patient. This is a 44-year-old woman who has this eye problem. Her eyelashes in the lower lid have disappeared. And what does she have? And if we look at this lesion here, this looks like discoid lupus erythematosus. That was indeed what she had. They treated the lupus erythematosus, discoid lupus erythematosus, which can be treated locally. This is called madarosis, and these lower lid eyelashes did not recover. That's it for this week. Join me again next week if you're interested in this kind of material. Thank you for being here. Was für ein Institut leitet